Good afternoon, everyone. I'm Chris Benko. I'm the CEO of Connexa, and I'm really pleased to welcome you to today's webinar on tracking physical activity in cancer. In the time I've been responsible for Connexa, which is about 6 years now, I've realized that the intuitive to folks, as it is in other disease areas where the applications seem a little bit more obvious. We've been very fortunate, almost our earliest days as a company with Ori, and we're really pleased to have him as a panelist today. Nitin is an associate professor of radiation oncology at Albert Einstein College of Medicine, and he's also at the front lines of treating oncology patients right across the river from us at Montefiore Medical Center in the Bronx. Our collaborations with Nitin have been outstanding and produced some great publications and great work that has taught us a lot about the potential for these technologies to really improve cancer treatment and cancer research. And so we're pleased to have him join us today to talk about some of those applications. Alongside Nitin is our own Chief Scientific Officer, Dr. Elena Ismailova. Elena has been a collaborator with Nitin since our time together at Connexa, but herself also has a deep background in working on oncology research and drug development, having started her industry career at Millennium Pharmaceuticals, which would later become Takeda, a prominent oncology company that has done a lot to advance medicines that are game changers for patients. So with that, I would like to remind all of our attendees that this session is being recorded. We do anticipate there will be time for Q&A at the end. There will also be an archive of this recording made available for folks who aren't able to attend. So thank you very much, Nitin and Elena. And Nitin, I believe I'm turning it over to you for the beginning part of the presentation.
Actually, I thought Elena was going to start.
My bad. Sorry, guys.
No, I will start, no problem.
My bad.
The next slide, please. So today, Dr. Ori will be talking about novel therapies and, to be specific, about challenges of selecting novel therapies. Recent scientific advancements in cancer research brought a number of new treatments to the market, and today, patients and their treating physicians have a conversation, which is the best therapy for this particular patient, who is fit for a specific treatment, and what would be a patient journey while they get certain anti-cancer therapy. There are tools out there that had been used for a while, such as performance status and quality of life assessment, to answer these questions. But given a plethora of therapies available today, these may not be the best tools. Wearables can be actually very helpful in answering these questions in both cancer research and care delivery. Today, Dr. Ori will share with you a very exciting, innovative research that Montefiore Medical Center is doing in partnership with Connexa to assess physical activity in patients who get anti-cancer therapy, to assess the outcomes of treatments, and he will talk about future direction in this really innovative field. The next slide, please. Speaking of challenges of selecting a therapy for a particular patient, I would like to highlight what is different today compared to 2 or 3 decades ago. And I'm going to be talking about 3 things. The first one, as I mentioned earlier, there are multiple therapies available today. In addition to treatments that we all heard of, such as radiotherapy or chemotherapy, there are new classes of drugs, targeted therapies that are designed to inhibit cancer growth in tumors that have specific genetic lesions. There are also immunotherapy treatments that specifically designed to activate patient immune system to target and kill cancer cells. However, with the number of therapies available, the question is, what is the best therapy for a particular patient? The second distinction that these days we have data emerging of how these anti-cancer therapies behave outside of randomized clinical trials. Randomized clinical trials are a gold standard methodology to bring novel treatments to the patients in the open market. It's a really good methodology to answer a question whether a new treatment can inhibit tumor growth, and usually it's being assessed in early stage clinical trials, and whether a novel therapy can have an impact on patient survival. This question is usually being answered in the late stage clinical trials when the new therapy is being compared to a control therapy, usually the standard of care. In order to test these therapies, people are being selected according to the study inclusion-exclusion criteria in order to create a well-controlled data set, and they are being randomized according to their baseline characteristics into the study arm, which helps to get to a clear answer: is this therapy helping? It provides an improvement, and these studies are statistically controlled to ensure that the results is not being achieved by chance. Real-world data is different. Due to widespread use of electronic health records, now it's possible to get data about the effectiveness of these therapies outside of randomized clinical trials and see how these treatments behave in a non-selected population. On this graph, I have the data presented last year at the meeting of Friends of Cancer Research, and these three graphs that you are seeing on a slide show real-world survival data taken from real-world data sources such as AHR on patient survival. So what you're seeing on these graphs is percent of patients who survived for a certain period of time shown on the x-axis and survival on the y-axis after start of a therapy. This data has been collected for patients with advanced non-small lung cancer who have received a combination of chemotherapies, checkpoint inhibitors that are on the market, or combination of chemo and checkpoint inhibitors, and every color line represents a different source of data because people worked together as a collaboration consortium to bring this real-world data from multiple databases, and the sources are listed on this slide. This data looks very different than the data from randomized clinical trials. Just looking at the survival curves, it's hard to tell which therapy is superior. And this is real-world data. It's how these drugs are prescribed, and this is how patients survive, which makes the choice of therapies even more challenging and indicates that more nuanced approaches are needed to understand which therapy is better for which patients. The third distinction is that patients are more active these days in the conversations with their treating physicians, and they ask questions what their life will be when they start a certain therapy, Anti-cancer therapy unfortunately come with significant toxicities, and it's not an easy decision. The next slide, please. I have here a testimonial from a breast cancer patient that was presented at the same meeting, and she shared her experience through her treatment journey. It was an eye-opening experience for me to hear this testimonial. The challenge that this particular patient faced was a choice of therapy because there was no data available for her specific situation. While she was talking with her treating oncologist, she asked a question: what would be the side effects specifically for me? How many adverse events I should expect? Would I have to go often to emergency room because some of these toxicities require an immediate medical care? Will I be able to exercise? This was a really important question for her, and there was no information available at that time because the standard drug approval endpoints such as response rate, whether treatment inhibits tumor growth, or progression-free survival, how long people live without a disease progression, do not offer information about quality of life or impact on patients' life, but these questions are really important. I was relieved to hear that this patient was doing very well. She completed her chemotherapy treatment. She experienced all these things that she was concerned about before starting a therapy, but she did very well. She was a survivor, and at the time of the meeting, she was cancer-free for several years. The next slide, please. There are instruments that help answer some of the questions about whether a patient is fit for a certain treatment. And this tool is performance status, which is a rating scale usually assigned by clinicians and based on people's apparent physical ability and activity level. There are two main scales used that you see on this slide: Karnofsky scale and Eastern Cooperative Oncology Group, briefly ECOG. These instruments are deeply ingrained in clinical research. Karnofsky scale was first published in 1949, and ECOG instrument was created in 1960. Since then, both instruments have been extremely instrumental in cancer research and advancing new therapies to the market because they have been shown to be predictive of patient survival. And they are standard part of the inclusion-exclusion criteria in clinical trials because only patients who can complete the study protocol procedures and treatment are being enrolled in clinical trials. They may also be used in routine clinical care when a physician needs to decide whether certain patients is fit for treatment or a certain more aggressive treatment is needed. The next slide, please. Like any rating scale, performance status has certain limitations, and the major limitation is rater biases in assessing performance status score. Here I have a few examples of this biases based for ECOG performance status, which is more often used than Karnofsky, simply because it's a simpler scale. In the first example is in advanced lung cancer patients that were receiving a different version of double chemotherapy. And patients who were enrolled in the sites in the US, Canada, and Western Europe and had performance status 2 had a median survival of 6.5 months. At the same time, patients with the same performance status enrolled in Eastern Europe had median survival of 9 months, which is more in line with lower grade performance status. It's a big issue for clinical trials because it's impossible to assess these differences until the study is completed and data is analyzed. It can also introduce biases and make results difficult to reproduce from study to study. The second example is shown on the right of this slide. Normally, performance status assessment is done by a clinician, but the rating can be also done by patients. And when clinician and patient ratings are compared, they are only 50% concordant. The top graph shows the rating done by a clinician, and the bottom graph shows the rating done by patients. As you can see from this graph, patients tend to assign themselves poor performance status score than their treating clinicians would be. The third difference, the third example is when performance status categories are being compared with objectively collected data, such as daily step count collected by physical activity trackers. There is correlation between performance status and the daily step counts, but there is a wide range among patients within each performance status category, which shows us that performance status on itself may be a very crude tool to understand the differences between different patients and provide sufficient sensitivity to assess novel treatments. The next slide, please. Quality of life assessments, it's another important tool. It's usually done via a self-report as patient-reported outcome, and there are a number of validated instruments available. However, one should be mindful of that as every self-assessment, these instruments have recall bias. Sometimes there is poor quality reporting, or it could be missing or inconsistent data. These instruments require an active input from a patient, and frequent administration of PRO instrument can create a burden for cancer patients. The next slide, please. And the last question I'm going to cover today, what regulators communicate concerning the topics of physical function and people's ability to live normal life. The FDA considers these sources as very important. They take them into consideration when assessing risk balance of novel therapies when they get these data in the submission package. And the FDA established multiple private and public sector collaborations to collect this data to answer the questions. What is a meaningful difference in function? How might function relate to toxicity or disease progression? Now I'm going to pass this presentation to Dr. Ori, who will give you concrete examples how these questions might be answered.
Thank you. And first off, I'd like to thank the team from Connexa for one, all the good collaboration over the years with much more to come, and two, for inviting me to speak today. So just to put sort of things into context, the way that I've envisioned wearables potentially enhancing cancer care, I think it could really, there are potential benefits all along the spectrum of a cancer patient's journey. So before treatment, if a physician was aware of the patient's functional status in an objective and data-driven manner, that could help us choose the right treatment for a given patient. During treatment, a lot of things can happen, some good, but also some bad regarding treatment toxicities. And I think having objective activity data can only help us detect when things are going wrong and when we need to provide some enhanced supportive care or change course somehow. And I'll show you some data to that effect shortly. And then also in the post-treatment setting or the survivorship setting, having objective data can help us monitor for late toxicities or disease recurrence. Hopefully neither of those are destined to occur and the patient's going to be a long-term survivor. And of course, then we have a sense that wearables could help patients maintain healthful lifestyles, which will help keep them out of trouble from other potential chronic diseases. So all this, any of this or all of this put together will hopefully improve clinical outcomes and reduce adverse events like hospitalizations, and all that will, of course, improve the quality of cancer care we can deliver and improve our healthcare value. Next slide, please. So in the last 5 or 6 years at Montefiore Einstein in the Bronx, we've had a series of clinical trials looking at the use of wearable devices in cancer patients. Many of these have been through my group in the Department of Radiation Oncology, but also other groups like our Gynecologic Oncology Department have been involved. And certainly we're always collaborating closely with other departments like Medical Oncology. Our initial studies were focused on patients receiving concurrent chemotherapy and radiotherapy as part of curative intent treatment for a variety of solid tumors. And in our recent studies, we've actually expanded to look at some other settings, such as patients receiving palliative systemic therapy for more advanced disease, as well as incorporating wearable devices into therapeutic studies, looking at novel combinations like immunotherapy and radiation without chemotherapy for lung cancer, or novel immunotherapeutic agents along with radiation for advanced lung cancer. In those studies, we're using wearable devices both to assess patients before treatment, but also to demonstrate how toxic or not toxic our treatments are and how patients maintain their functional status throughout the treatment course. Regarding the specific devices we've been using, the vast majority of our trials have been using a Garmin VivoFit, which is a relatively simple and inexpensive device and very user-friendly. It's waterproof, does not need to be charged, and holds data for about 3 weeks. So we find this to be very good for our patient population, which is not necessarily very tech-savvy. And the patients, we just ask them to wear the device all the time, and anytime they come into the clinic, we can grab the data using a wireless hub. Next slide, please. So first, I'll focus on some of the data we've generated about how activity data can help evaluate patients before treatment. Next slide, please. So all of you will be aware of this loose recommendation that people should average 10,000 steps a day. Many of you will also be aware that that's not really based on any evidence, and that certain patient populations really cannot keep up with that. So there's one review paper here that nicely mentions that certainly older adults and patients with chronic diseases such as cancer will not be able to keep up with that. And that has certainly been our experience in the Bronx. Next slide, please. So in our patients, on our various studies, we've seen an average of about 5,000 steps a day as an average patient, but certainly with a wide range depending on the particular patient. Next slide, please. So in trying to put our patients' activity data into context, we really found it challenging as there's not much published normative data. Here's one example of something that we have found useful. This is a study out of Australia looking at older patients without cancer, providing a nice breakdown of the distribution of daily step counts as a function of age. Next slide, please. So using that as a framework, we've made sort of 3 broad categories of patient activity. Patients who would fall below the 25th percentile of what you'd expect for their age, we call inactive. Patients above that we call active, and patients above the 75th percentile we call very active. So here on this busy figure on the right, we've created a scatter plot of about 200 patients, our initial patients. All these patients went on to receive chemotherapy and radiation concurrently. But this is really just focusing on their pre-treatment step count average. And so far, most of what we've done is with step counts, but obviously wearable devices can give us much more data that we can play with in the future. So you can see certainly there's a wide distribution of our patients, most of them being either inactive or active, with very few being very active. We've used symbols to describe the performance status, and you can see that there's not really a huge overlap in terms of performance status is sort of independent of baseline activity levels. So I do believe that the daily step counts are providing new information that we did not have before. Next slide, please. So here's that in just another form. The same data on the right is in some bar graphs, and you can see that among the patient performance status 2 patients, none of them are very active, so at least we as physicians have recognized that part. But short of that, there's not really much discrimination, and certainly between performance status 0 and 1, those 2 groups look about the same in terms of activity. Next slide, please. So our first disease set we've really been able to analyze and demonstrate that baseline step counts, a very simple metric that's pretty easy to obtain if your patient already has a wearable device or if you give them one for a few days. We found that this activity group is actually a tremendous potential prognostic factor that far outperforms anything else that we use in the lung cancer world. So here you can see just from 50 patients receiving concurrent chemoradiotherapy for locally advanced non-small cell lung cancer, so very much a homogeneous patient population. Patients who were inactive had a tremendously higher rate of hospitalization during the radiation course compared to other subjects. Also, it's far more common for inactive patients to have significant delays in the completion of their radiation, and that's a factor that we know detracts from treatment efficacy. And then the sort of long-term clinical outcomes of progression-free survival and overall survival. Tremendous differences between inactive patients and other patients. Next slide, please. Yes. So this is to say that I think it's quite clear to me, and hopefully others will agree, that daily step counts or some measure of physical function should be a prognostic factor when you're evaluating a given patient or within a given patient population. To me, the next big question is if these activity metrics would predict which patients would benefit from a particular type of therapy. Now, unfortunately, we don't have any data to address this yet, because as far as I know, nobody's including wearable devices in the potentially practice-changing phase 3 therapeutic studies that are being conducted and presented and published these days. So I think that's really imperative that we start to include this data in our practice-changing studies to really define which subgroups of patients benefit the most from more aggressive treatments. Next slide, please. So moving on to work we've done looking at our patients during therapy. Next slide, please. So this is a figure from our initial pilot study of about 40 subjects receiving chemoradiotherapy for a variety of mostly head and neck, lung, and GI tumors. And on the left is the spaghetti plot of the patient's activity level throughout the treatment course. And obviously you can see it's a very busy slide. Each line is an individual patient. So there's certainly a roller coaster ride throughout the treatment course for some patients. And the triangles are actually hospitalizations. So about a third of our patients were hospitalized during the treatment course. And clearly you can see the trend for the hospitalizations to occur among patients who have not been walking much recently. The multivariable modeling came out to a 38% reduction in the risk of hospitalization for every 1,000 steps taken in a given day. So this is to us a clear signal that step counts not only at baseline are a prognostic factor, but during treatment can be a dynamic prognostic factor for short-term outcomes like hospitalization. Next slide, please. So in our first study, we were sort of tabulating the activity data from the Garmin site manually, but since then we've been fortunate to team up with Connexa who's helped us analyze the next few hundred patients. And so we did put this together and presented last year with our colleagues from Connexa, looking at a much larger data set and looking at the same question of how do daily step counts predict hospitalization risk during chemoradiotherapy. And we found almost the same exact finding here, 36% reduction in the risk of hospitalization for every 1,000 steps taken. And also when we have enough data, we can compare the ability of step counts to other metrics such as performance status or patient-reported quality of life, which we are collecting for all of our patients, to predict hospitalizations. And we find that step counts are by far the most sensitive and specific way to predict how your patient's going to do. In particular, a decline in step counts compared to the prior week seems to be a very important factor in predicting when bad things may be looming. Next slide, please. So we have this leads me to believe there's sort of two things we need to study in the setting of patients going through active, aggressive, and potentially toxic cancer therapy. And both of those we're making some efforts in. The first is, should step counts be a new vital sign? And should we in clinic be focusing on daily step counts and reacting to them somehow to enhance the supportive care we provide, address perhaps instead of seeing patients on a routine schedule like once every week or once every 2 weeks based on the calendar, we should be seeing patients in a more reactive fashion based on the activity data. The other side of the coin is, could there be sort of a chicken and egg phenomenon? If we could somehow increase our patients' activity level through some kind of perhaps exercise or walking intervention, could that actually improve their tolerance of treatment? There's a lot of preclinical data and some clinical information indicating that physical activity can reduce systemic inflammation burden, and that potentially could reduce the side effects that are caused by treatments such as radiotherapy. And we have studies going on to address both of those. Next slide, please. So finally, the post-treatment setting, and I'll won't dwell on this much because it's not been an area of our personal focus. Next slide, please. So suffice it to say that others are studying this in a big way, in particular in diseases like breast cancer, where most patients are destined to be survivors, and perhaps the comorbidity burden is not that high on average. So here's an example of that. This is a huge phase 3 study going on as part of one of the NCI-sponsored cooperative oncology groups with over 3,000 patients who have survived breast cancer being randomized to receive standard management versus a more aggressive intervention with the aim of causing weight loss, which would be beneficial for several reasons. One, for just general health, but also for reducing estrogen throughout the body and perhaps reducing the risk of breast cancer recurrence. So this is a huge effort going on with a multifaceted weight loss intervention that does include a Fitbit device. Next slide, please. So to conclude, I hope I've convinced you there's a lot of possibilities for activity data to really enhance the care we provide to our cancer patients. I've mentioned this sort of over the time, before, during, and after treatment, we can provide gains at all time points. Also, this could be pertinent to all sorts of patient populations and all sorts of treatment modalities. So patients receiving surgical resection could benefit from some sort of prehabilitation or using activity data to decide who's fit for surgery. Certainly, I've been focusing on patients receiving radiation, and all of this also seems to apply to patients receiving systemic therapy with cytotoxic chemotherapy or immunotherapy. And again, activity data could be considered a vital sign or a prognostic factor. It also could be the basis of some kind of intervention. And I do believe that when trying novel treatments, activity data could perhaps be a great way of measuring toxicity, in addition to the standard adverse event measurement tools. If you're really trying to objectively demonstrate that one treatment is better tolerated than another, incorporating activity data may be a great way to do that with a modest sample size. And so I'll stop there, and I'm happy to take any questions.
Thanks, Nitin. That was great, and I'm going to help out with routing the questions that are coming in over the web. You were starting to talk about this, but I'll invite you to potentially expand on it, or maybe Elena wants to weigh in as well. And it was this, the question is, are there specific treatment modalities that are better suited for incorporating physical activity tracking or certain types of cancer? Now, I know you were alluding to the fact that this can really be relevant in a wide variety of different treatment areas, but are there specific areas or types of cancer that you think are particularly promising or interesting?
No, that's a great question, and I think there's different types of gains that could be had in all patient populations. I'm finding with some of my older and sicker lung cancer patients, for example, I'm not having much success in motivating them to move more in our randomized trial of a walking intervention. But then again, those are the patients that probably benefit the most from following their step counts as a vital sign. Other patient populations would be sort of just the opposite. So it seems to me that the data is so easy to collect and really can help in so many different ways. It's, to me, worth studying in every facet, and we really just need interested investigators and just some minimal infrastructure to incorporate the activity data into our clinical routine.
Great. So another question that's come in is, has patient satisfaction of physical activity tracking been studied? And what is the patient engagement for physical activity tracking?
So another good question. To the first, I guess I've so far, I've not been studying my patient satisfaction with the activity monitoring. Where I work, I think most of my patients are happy to just get a free watch. Most of them are willing to keep it on. The ones who do take it off, often that's somewhat informative. I think if they realize that their activity is really dwindling, there may be some sense of, well, I'm not walking anyway, why should I wear this? Or maybe even some embarrassment. So the missing data is not totally uninformative. So regarding the patient engagement, my patient population will certainly wear the device. I've had a very small minority of patients really engaging with the device and monitoring their own step counts, or if we've had 250 or so subjects on our trials, only a couple have actually wanted to know what's the account login info so I can see the steps myself. But I realize I work in a sort of unique patient population in some ways, so in other settings, I imagine that's quite different.
And do you want to expand on that just for the benefit of folks who don't understand or aren't necessarily as familiar with Montefiore and the population whom you guys serve?
Sure. So we're sort of the lead academic medical center in the Bronx, which is, obviously New York City, and I think even if it was just the Bronx without the rest of New York, would be one of the top 5 cities in the country in terms of population. We also, I think, rank right at the top regarding poverty rates, and we also have a very diverse population with a large minority, if not a majority, of our patients. Certainly a majority of our patients are ethnic or racial minorities, and many of them don't speak English. Certainly our patients are uniquely in need of anything we can do to help them, and I guess activity data seems to be potentially extra helpful for our patients where there may be some hesitancy on the patient's part or language barrier or something preventing effective communication by traditional means. The step counts sometimes are far more telling than anything else we're able to glean from the patient.
Now, thank you. I think that's important to clarify because there's obviously huge issues with disparities in access to care, but also participation in clinical trials for minority populations. And I think often misconceptions or preconceived notions about differences in how folks will respond to some of these kinds of interventions. We have some other questions coming in, so I'll keep moving. The next one is, I believe there is a need to remove the baseline effect of patient lifestyle. Some patients are more active than others naturally, so that the clinical results are not misleading. Can either of you comment on how this can be incorporated? Yeah,
certainly every patient in our, we generally our statistical methods have involved some mixed effects modeling, so sort of each patient serves as their own control when looking at dynamic changes and predicting things like hospitalization. I will point out that if you look at the actual numbers we're talking about, we're often talking about huge changes that are, somebody's going from walking 10,000 steps a day to walking 1,000 steps a day. So clearly something's wrong there. And you're right, if that patient was always walking 1,000 steps a day, that, may not be such a big deal. So I agree that looking at the dynamics is key. And again, so far we've been sort of just scratching the surface of looking at daily step counts. There's much more nuanced data regarding looking at smaller, time bins to see when patients are very active or if they're ever very active, and things like machine learning might help develop some more nuanced predictive models using our data.
Great. Next question comes from a name I recognize, Dr. Bill Wood, from the University of North Carolina, a fellow oncologist, although he's focused on blood cancers and transplantation. Great presentation, and I agree this has value to predict and reduce toxicity from cancer treatments. Thoughts about the right metrics, steps, something else, and period of time, days, week. If an alert is generated based on activity, what is the right response?
That's a great question, and I know UNC's group is led by one of the pioneers in electronic patient-reported outcomes in predicting adverse events in cancer patients. So those are very good questions. I think daily step counts is at least easy to collect and easy to interpret. So that certainly seems like a good place to start. But I agree that there may be more nuanced metrics that are telling, even using different measures. Things like heart rate variability would be great if we could capture that using fancier devices in all our patients, and I'm sure we will soon. Regarding what the alert system should be, I think that although I'm quite convinced that step counts matter, I don't think we're at the point where we need to, I don't think if we see a low step count that we're bound to put a patient in the hospital or do something like that. But those are things we're considering, and with more data, we can hopefully come up with a framework in which, in a future trial of activity monitoring, we will come up with a sort of rigorous algorithm of when patients need to be seen in the clinic, when they need, what supportive care measures need to be enacted. For patients receiving daily radiation, we're seeing them basically every day, at least some of our team members are, so it's less of an issue. But as we move this program more towards patients receiving systemic therapy every few weeks and collecting data from their homes, this will all become very relevant.
I would like to add a few words here because it's such a good question that there is some nuances to the data that we didn't cover in the presentation for the sake of time, but there are a number of ways how to slice and dice these data, and definitely there is variability in a step count between weekdays and weekends, and data collected over the weekends when people physical activity are not constrained by other commitments such as work is better predictive than data collected over weekdays. For the results that Dr. Ori showed with you from this large near 200 patient cohort, we average daily step count over the period of 3 days, and that was a very good dynamic predictors. There are also additional ways to probably to explore this data because it has a great potential, and we are in the progress of doing some additional research and also linking with survival data. This is one of the future goals of this program.
Thanks, Elena. So our next question is physical activity measured through a watch is just a proxy to overall physical activity. for example, cycling is not detected, bicycling. Should we look for more robust measures for physical activity?
Yeah, certainly more information would be better. I think, again, also depends on what the question is. When I started this, I was looking at what kind of questionnaires to use about our cancer patients' physical activity, and I found, surveys that were asking about activities like cross-country skiing, and I think at least in my patient population, very few of my patients are doing any kind of exercise intentionally. And those who are, in addition to the exercise, just through their normal daily activities, would end up being in our sort of very active group for their age. So I agree that, for the high-performing patients, being able to measure things like cycling and other activities would be helpful. Again, and everything needs to be sort of customized to the patient setting. And the patients I'm dealing with, that's really almost a non-factor, unfortunately.
Got it. That makes sense. So next question comes from Victor Chan, who's an oncology researcher at Genentech. What additional measures would you consider collecting from a wearable to create a more robust biomarker? So slightly different kind of version of that question, not necessarily oriented just at physical activity, but what other measures would be really interesting to consider?
Sure. So certainly, for our patients who are at risk for nutritional issues and other, for other reasons, can get dehydrated. So, following things like heart rate and blood pressure would be great. Pulse ox, especially for some of our like lung cancer patients, especially. Heart rate variability, I think, is exciting, and there's a lot of data emerging that having a lack of heart rate variability could be a sign of a patient not doing well in one way or another. So I think it's all going to help. The more we can get, the better. So again, I think we're just scratching the surface.
Great. The next question comes from Betsy Malkus at Ultragenyx Pharmaceuticals. And let me know if either of you want any other support on this question, because it may be a little bit more in my camp, but you may have the answer. How do you handle the data storage and transfer, et cetera, for the Garmin VivoFit to meet 21 CFR Part 11 compliance?
So I use you guys.
That's yeah, that's a great question. Sorry, Nitin. I figured I would give the panelists the opportunity first, but it is a really important question. So 21 CFR Part 11 is a regulation that is specific to how it is a guidance specific to how we operate and manage data in clinical trials. What we do is we actually integrate directly with Garmin to import the data into Connexa's platform, which is specifically designed for doing research in drug development. So we follow specific procedures for security, privacy, data at rest and in motion. And there's a lot of additional work that we do to make sure that we protect any personally identifiable health information, and any vendors that we integrate into our platform are qualified for that. So yeah, that is why one of the reasons that we work together to make sure that data is protected. The next question is, other than the activity tracker placed on the wrist, did you try placing the tracker in other parts of the body, such as the waist or the hip? Is there any preference for one over the other? It's an interesting general question about the use of activity monitors and how they capture data from people.
So we've just been using the wrist, and certainly that's not perfect or comprehensive. We basically enrolled anybody who's walking, even using a cane, but we're not enrolling patients who use walkers, where they could be moving around without swinging their arms. And I know that, no pedometer or activity tracker is 100% accurate, but again, the sort of magnitude of changes we're looking at, I think any device that's out there would be good enough for these basic step counts.
I will add a little bit here. These specific devices are designed as wrist-worn devices, and to ensure patient compliance, it's better to use them the way how they intended to be used by a manufacturers. These are very lightweight devices. I tried some of them, and after a while, I forgot even that I was wearing these devices. It's a very seamless integration. Placing these devices on other parts of the body, like such as waist and hip, will require an extra effort and may impact data collection compliance. And I wanted to add here that in our studies with Montefiore, the compliance was extremely high. In one of the pilot experiments, a primary endpoint was to assess patient compliance, and we hit 95% mark, which is remarkable.
Thanks, Elena. That's a great add. This next question is from Jakub Travinsky at Novartis Pharmaceuticals. Great presentation. If physical activity is important to the patients, which is something we determine when designing our clinical trials, we would always try to measure it with the best method. I am not sure if step count is the best proxy for that. To have a more complete view, it would be interesting to combine it with phone assessments or EPROs, electronic patient reported outcomes. Are you planning to expand on the parameters in your research?
Yeah, so I didn't dwell on it too much, but all of our studies have included quality of life assessments, initially using the EORTC tools and more recently with the PRO CTCAE. Again, based on our patient population, we've just been giving them paper forms. Most of them are not computer savvy and will not really do well with doing it from home or on a computer. And even if we have an iPad in clinic for some of our clinical trials that require us to collect the ePROs using the iPad rather than a paper form, but then our coordinator just ends up doing it with the patient because many of our patients are just not ready for that yet. But either way, I agree that comparing and adding the activity data and the patient-reported data would be the best way to do it. To the first sort of part of the statement about collecting the data in the best way possible, I agree that that would be ideal, but I think perfection is the enemy of good sometimes, and we really, if you're not doing anything, the first step is to use some kind of device or collect some kind of objective data. And ePROs are good and probably better than physician or clinician rated assessments in many ways, but I think the objective activity data will even outperform ePROs in a lot of settings.
I'm just going to add here that some of the data that Dr. Ori shared in this presentation actually included the data from quality of life PROs, specifically QLQ-C30 instrument. And in our research, physical activity data from fitness trackers was far superior than the most recent quality of life assessment in predicting hospitalizations.
Right. And of course, there are other studies where we are able to collect both. Certainly some of the work that we've done with Takeda on their NINLARO programs that's been published. Specifically, we collect EPRO data on a mobile phone when we can. And I think as you nicely put it, it comes down to also understanding the usability and feasibility with the target patient population and what they're going through. Thank you both so much. I've seen a lot of this data, but there were a lot of insights here, even for me as somebody who's familiar with your work. I learned a lot. So, Nitin, I appreciate you taking the time out of your day, which I know is busy with clinical care, in addition to all your research interests, and Elena as well. I know a lot of work goes into preparing these presentations, but it's such an important topic. I'm glad that we could make this available. So thank you both so much, and take care and enjoy the rest of your afternoon. This will conclude the webcast and the recording.
Thank you.
Thank you, guys.